So now I'm going to demonstrate how the tutors will interweave the given subsections of a chapter in first aid together to better prepare the students for seeing these type of MBME style questions that require you to take one section of first aid and apply it to another to come up with the right answer choice here. So we encourage the students to force themselves to do this on their own with their studying, but of course the tutors will definitely push this emphasis in the studying approach. Okay, so let's start off here with gout. Now, gout is a very high yield pathology, and it's a monoarthritis that is caused by precipitation of monosodium urate crystals, okay? And the practice tests want us to know that because this sets it apart from its counterpart, pseudo-gout, whose actually symptomatology is brought upon by precipitation of calcium pyrophosphate crystals. Okay, so there is an association here, of course, with hyperuricemia, but I can tell you 100% there's going to be an MBME question that wants you to know the most common cause of gout, okay? And the right answer choice is actually due to underexcretion of uric acid. As we see here, 90% of the gout population has a problem with underexcretion versus the 10% that are due to overproduction. Okay, so we do see that certain medications can precipitate this underexcretion, so we want to be careful with hypertensive patients taking hydrochlorothiazide and so on. All right, so something that used to be a lot more high yield is going to be knowing that on crystal examination of monosodium urate within the joint fluid, you will see needle-shaped negative birefringent crystals here, and this again will set it apart from pseudogout. But I think more of a high yield topic these days is knowing about tumor lysis syndrome. Okay, so this is only recently added in first aid. And basically what happens is when you're treating something like a lymphoma with chemotherapy or radiotherapy, that lysing open of all those cancer cells basically allows the uric acid that is a component of the purines and pyrimidines within the nucleus of those cancer cells to escape and actually, elevate the uric acid in the serum here. Okay, so you will see that this overproduction is due to this PRPP excess. And this excess here, basically what you want to realize that gout can occur with an increased frequency in patients with activating mutations of what we call 5' phosphoribo 1 pyrophosphate, okay? And this basically will elevate purines, which will eventually elevate uric acid and then lead to exacerbations of an underlying gout here. So symptoms here are usually, one joint that's swollen, red, and painful here. And the questions will give you this huge clue that usually the patient will be binge drinking the night before, have an excess amount of alcohol the night before, and then they'll present with this painful big toe that we call podagra that's shown in the picture here below. So the alcohol history is definitely important for connecting the dots here. Okay, I do want you to realize though, first of all, they go on to talk about tophus formation. Okay, now they don't tell us what a tophus is, and tophi or tophus is basically aggregations of uric acid crystals that are surrounded by inflammation. And I can guarantee you're going to see the MBME question that says, which of the following is the most common site for tophus formation to take place? The right answer is going to be the external ear. Okay, so they definitely like their most commons on the MBME exam. So here's the part I was referring to, that the acute attacks usually due to alcohol consumption here, and this is because alcohol is going to compete for the same excretion sites as uric acid in the kidneys here, so it can lead to buildup in the blood. Now, we are talking a lot about uric acid here, but what you want to realize is that, just because serum uric acid is high doesn't mean that's going to be predictive of gout. People that have gout episodes can have a normal uric acid, so just something to keep in mind when you're going through the questions here. Now, the thing that really brings us here is going to be the treatment, okay? There's no way you're not going to get asked how to treat acute gout attacks. Now, basically what you want to realize is that colchicine is never going to be the right answer for your best initial choice of therapy, okay? You want to realize that NSAIDs, particularly the best studied endomethacin, will be your best choice for therapy and treatment for acute gout. Now, I would say that NSAIDs are first line, colchicine then is second line, and we have to keep in mind that colchicine has a very difficult side effect profile of GI upsets and diarrhea, so that's why it's not first line. And of course, glucocorticoids may even be given in the more severe acute attacks. All right, so they tell us, of course, here that NSAIDs are going to be, adequate treatment here for gouts, but they don't tell us why. So we encourage students, and of course the tutors will do this during the sessions, to go on and then think about why would NSAIDs help to decrease the symptomatology in a gouty attack. And we do see here on the arachidonic acid pathway that NSAIDs are listed here as cyclooxygenase inhibitors here. Now, of course, what you want to realize here is that beyond cyclooxygenase, we see that if we're not inhibiting, we see prostacyclin, prostaglandins, and thromboxane basically, causing a multitude of changes within our, both our coagulation as well as our immune pathways here. So NSAIDs are, of course, going to be cyclooxygenase inhibitors. Now, remember that COX-1 actually makes prostaglandins and protects the GI tract or the guts, and COX-2 is more so involved in inflammation here. So basically, inhibiting cyclooxygenase is going to allow us to decrease a lot of the things that are seen with inflammation. Okay, this is pain, redness, swelling, loss of function, these type of things that come hand in hand with this precipitation of these monosodium urate crystals here. So side effects for NSAIDs are very minimal, and that's why they're first line. We mentioned colchicine, which is a microtubule inhibitor, actually has more of a rigorous and brutal side effect profile. And then third line here we mentioned are glucocorticoids. Okay, so we see here that corticosteroids are actually listed further up the chain for the arachidonic acid pathway. So if we inhibit phospholipase A2 with corticosteroids, we're actually stopping this pathway sooner than would otherwise be the case. Okay, so not only would you inhibit the right side of this pathway with cyclooxygenase, but you would also decrease, leukotrienes, and that includes neutrophil chemotaxis, which can, of course, also contribute to your inflammatory response. So basically, something to keep in mind here is it seems that corticosteroids would be better because it's inhibiting more of the pathway. However, because of the many side effects of corticosteroids, especially, long-term use leading to Cushing's and avascular necrosis, it can lead to difficulties controlling blood sugar, even insomnia, and in some severe cases, psychosis. So we try to avoid the drugs that have the worst side effects on your step one exam. Okay, so this is kind of how you want to say, well, first line treatment for acute gout is broken down in such a fashion here, okay? And then the gout section goes on to tell us, on chronic basis, we're trying to prevent, okay? So that's when you can, tie in the allopurinol, which is a xanthine oxidase inhibitor here. And they do give us a pretty good picture of this uric acid crystal, which will of course be surrounded by inflammation here. So that's really how to tie path to pharm. So pathophys, that we reviewed in addition to some pharmacology as to why the first line treatment of acute gout is the way that it is. Okay, so let's go on to continue another demonstration.